Hello everyone. Today we are going to discuss another case in pregnancy, that is how to treat malaria in pregnancy. So let us start the case. So a pregnant lady presents to your OPD or at your office or at clinic, or she's at the ward, and you have been called for a consultation. And they describe that the patient had headache, fever with chills and rigors, body aches, fatigue, sweating, and they did a test for her, or you are the OPD, you did a test for her, that is MP, malarial parasite test, and that came to be positive, as it is a gold standard for peripheral blood. For pregnant lady, the gold standard is placental histology, but still MP test is still done. And you will also do other of the tests like CBCs, LFTs, RFTs, urinary and serum electrolytes plus lactate. So now this is a one whole case. So how would you manage such patient in your OPD or at a consultation? So there has been a division of malaria, that complicated malaria or uncomplicated malaria. So for it, we will go with first with the uncomplicated malaria. If the patient is in the first trimester, then we need to treat her by tablet quinine 300 mg TDS and tablet clindamycin 300 mg TDS for 3 days. Or alternative, we can give the tablet artemether 80 mg and lufentrine 40 mg VD for 3 days. So before, the WHO recommendations were to avoid artemisinin-based combination therapy in the first trimester, but they were updated in 2015 following updated evidence showing no increase in the risk of miscarriage, stillbirths, or major congenital malformations as compared to quinine. So most of the evidence related to ACT therefore should be preferred, that you should use ACT in the all trimesters. It's safely you can use ACT based medications. And you can check up the latest editions, latest articles about how the pregnancy are being managed, and this is one of the after 2015 guidelines. So this is uncomplicated malaria. Let's suppose the patient have severe malaria for all trimesters. So how would you manage the patient? You will give the patient injection artesunate for 30, 60 mg, 120 mg IV or IM at the dose of 2.4 kg at 0 at start, and then after 12 hours later, 24 hours, and then daily thereafter for 3 days, or until malarial load becomes less. Or for the next 3 days, you need to continue with ACT, artemether, and lufentrine BID orally for 3 days. And if the artesunate is not available, so you need to give injection artemether 40 mg or 80 mg per ml at a dosage of 3.2 mg per kg as a loading dose, and then you need to continue with 1.6 mg per kg daily until able to tolerate oral dose of ACT for next 3 days. So you need to give. For severe malaria, you have the choice of giving the patient with injection and then converting to oral dose. But with the uncomplicated one, you need to start with the oral dose. So you should remember you have two choices, and the preferred choice is the artemether and then changing into ACT combination for the next 3 days. So remember, these drugs can be safely used in pregnancy. Next, the patient have fever. So for symptomatic treatment, you can give Panadol, and you need to correct hypoglycemia if there is any, monitor vitals, check all the labs like RFT, LFTs, bilirubin. So you need to monitor all these things. And you should remember, the pregnant lady, whenever she has uncomplicated malaria, she should be admitted to ward. And if she has severe or complicated malaria, then she need to be admitted to ICU. So pregnant lady should be high concern for treating them in the hospital. I hope you have learned something new, and this would help you in managing malaria wherever you are. Thank you for watching. Please like and subscribe my channel. Thank you so much.